Lots of people are talking about HBO's The Pitt, a captivating, realistic depiction of the challenges facing healthcare workers in the modern hospital setting. We'll see about that. Now, I tend to avoid medical dramas because frankly, most of them get a lot wrong, which I find frustrating having spent so much time on the front lines, so to speak.
There have been many medical shows, and this is something you haven't seen before.
We really want this to be the most accurate medical show that we've ever had on TV.
Life in the hospital, and especially the ER, is challenging and nuanced, with moments of intensity, compassion, and humanity that don't always fit neatly into an hour-long TV episode. I'm sure you can smell it already, but I walked into the first episode a grizzled skeptic. The premise, where each episode covers roughly an hour of a 15-hour trauma shift, isn't problematic in and of itself, but holy crap. The Pitt may be as well located in downtown Gotham on the eve of the freaking purge. This level of action makes for great TV, but it is highly unlikely in a single emergency department unless all other hospitals in the area are closed for some reason.
There's a nursing shortage across the country.
Okay, now, I know this video is supposed to cover everything that I liked about this show, but I had to get that little bit off my chest. Overall, I was pleasantly surprised, and I found a whole 13 things worth celebrating in episode 1. Oh, and don't worry, we'll save the things that I didn't like so much for next week's video, for those of you that love a little internet drama. And if you like content like this and you want to see more of it, then subscribe to the channel and turn your notifications on so you don't miss an upload. And I would appreciate the favor if you like the video and share it with someone interested in learning about medical topics. Okay, Dr. Robbie, take it away, my brother. Yeah, I mean, the emergency department gets busy, especially in urban locations. One of the reasons why you'll spend so much time waiting is because we're working to make sense of everything behind the scenes. For every 2 to 3 walk-in patients, we might have one person arrive by ambulance, likely in greater need of immediate attention. When patients arrive, we need to triage patients by severity and determine whether a person belongs in trauma bays for critically injured patients requiring immediate attention, acute care for patients with severe, life-threatening conditions needing close monitoring, subacute care for patients who were in acute care but are now more stable, stable ambulatory area for patients with minor injuries or conditions who can walk and don't require intensive care, the isolation area for patients with infectious diseases to prevent transmission to others, and the psychiatric area for patients with mental health issues or behavioral emergencies. There's a lot going on, and I think the Pitt captures the hustle and bustle pretty effectively here.
Had a guy come in, hit by a drunk driver in a crosswalk, 39-year-old vet.
Yeah, this hits home. You're gonna deal with some shit, especially on an emergency shift. No two ways about it. And sometimes you'll need to step outside and get some air, like for real.
Survived 3 tours without a scratch. I spent the last 2 hours coding him.
When he says he spent the last 2 hours coding him, he's referring to a trauma code. Think of this like a 911 call within the hospital ecosystem, or the classic Avengers! Assemble. When somebody comes into the hospital who is actively dying, this is a hospital-wide call to action that gets all hands on deck. Emergency physician, general surgeon, orthopedic surgeon, anesthesia, respiratory tech, multiple nurses, radiology tech. So no matter what the issue is the patient is dealing with, there is someone equipped to address that problem.
There were so many people responding to his situation. It was incredible.
Typically, either the emerge doc or the general surgeon will take over as team leader to direct everyone else what to do. You learn to be ready for anything, and no matter how many trauma codes occur in a given shift, we still need to be efficient with our time, as Dr. Robbie alludes to here.
As you can see, our house is always packed, and our department is mostly clogged up with boarders. Those are admitted patients waiting for a room upstairs, sometimes for days.
Yes, there are usually more patients than there are beds, and always more on the way. On this particular morning, Robbie is our head TTL, or head trauma team leader, who happens to be overseeing 2 trauma codes at once with 2 TTLs working under him.
Your senior residents are Dr. Collins and Dr. Langdon. You report to them, they report to me.
These interactions are all pretty accurate, as each team must first work through what is known as the ATLS, or Advanced Trauma Life Support Protocol. The ATLS protocol involves the following steps: assessing the ABCs, airway, breathing, and circulation, quickly evaluating injuries, head-to-toe exam and imaging studies, controlling life-threatening injuries, stopping bleeding, relieving pressure, etc., resuscitating, fluids, blood transfusions, airway management, stabilizing, immobilizing fractures, and transferring to a care facility.
Do you speak any English? Airway and breathing are perfect.
As is circulation.
ABCs, baby. You see, this is step one. Obviously, this woman who had her leg caught in between a train and the subway platform has a primary injury that is quite easy to identify. They'll work to stop the bleeding at the primary injury site, quickly check the rest of the body for secondary injuries, and on it goes. As you might expect, the application of each step in the ATLS protocol will vary from patient to patient.
Pupils 4 millimeters and reactive.
Okay, that's encouraging.
What do you want for meds?
120 ketamine, 80 of rock.
This man experienced blunt force trauma to the head and will require different things than the previous patient. No matter the injury, the goal of the ATLS protocol is to stabilize the patient so their life is no longer in immediate danger. From there, we begin to assess how bad the injury is and what must be done to fix it.
Like I said, there's a nursing shortage.
Well, if you paid them a living wage, they'd be lining up to work here.
Our budget can't support that.
Money, 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 money. Money! What can you do? When I got into healthcare, I didn't expect budget to be so embedded in conversations pertaining to the health of our patients. Now, I know better. Whether you like it or not, a hospital is a business. And the stark economic reality is that healthcare professionals are tasked with running that business with insufficient funds to do what is required.
Here's a dirty little secret. The hospital saves money keeping patients down here in the pit. It's way cheaper than staffing upstairs.
No matter what problems we are faced with, there is never enough money nor resources to do what we think is necessary for the patients under our care. I don't recall a time when I heard a doctor say that their department had more than enough money to provide the care for their patients. Finance isn't the only reality that hits rookie doctors like a ton of bricks. Two attending physicians are pulling the patient's leg in opposite directions to reduce a very severe tibial fracture. That is, pulling the fragments of bone away from each other before setting them back in place. Voila! When the outer layers of tissue have been destroyed, this can look like something out of a zombie film.
Med student down.
So yeah, this does happen. In fact, it's happened right beside me multiple times. As a student, that third year rolls around, could be second for some with electives, and you may think you're ready. But when the blood starts flying and the reality of it all hits you for the first time, timber! We literally tell students to sit on a stool for their first time in the operating room. Closer distance to the floor, should they be overwhelmed by the sight of something and suddenly find themselves unconscious. Love this little touch. We wash our hands a ton before entry to each room, after each procedure, after touching a patient, and after removing PPE or personal protective equipment, gloves, masks, etc. You know, anything that creates a barrier between us and the germs. We need to be diligent in order to protect ourselves, our colleagues, and patients from bacteria and other contaminants. And although there are some people who don't ascribe to the germ theory of infection, I assure you that it is real and it is a problem. On the severe end of infection, we get
Call code sepsis.
Code?
To make sure we check all of our boxes, the federal government audits our sepsis bundle performance.
So sepsis occurs when the body's immune system has an extreme response to an infection. We may call code sepsis if a patient is crashing without any obvious sign of other bodily injury, as sepsis may coincide with a severe sudden drop in blood pressure. Calling code sepsis is meant to hasten sepsis recognition and treatment. It's funny, we kind of throw the word code around pretty often in the hospital. Sepsis, trauma code, just a moment ago, and in a few moments.
Stop. Call it. Nursing home just faxed us a DNR.
kidding.
Power out the defibrillator.
Well, our head nurse Dana doesn't say code, but when she tells the team to stop resuscitating the patient, she is referring to a code directive. When dealing with elderly patients, we need to know how far we can go to save your life. That is to say, steps you want the medical team to take if your heart and lungs stop working. Full code means chest compressions, shock, CPR, and intubation. The whole 9 yards. The DNR that Dana refers to means if the heart and lungs stop working, do not resuscitate. When assigned this code directive, the patient either doesn't want life support or is unlikely to survive. I mean, these steps can be absolutely brutal. For example, chest compressions typically crack the ribs on an elderly patient and make whatever time they do have left afterwards extremely painful.
Complete waste of time and money. Who the hell works at that place?
A nurse taking care of 60 patients who couldn't find the form.
She called 911 so she could take care of the others.
I mean, yeah, we lose people all the time, and it is challenging. That and people make mistakes all the time. Best not to be a dick about it, so I appreciate Dr. Robbie's demeanor here and how he checks the resident.
One of the things we do here is to take a moment of silence when we lose a patient.
No matter how exhausted or frustrated you are, our patients are people with real lives. We need to respect that. More points awarded to the Pitt writing team.
So what rotation is this for you?
Third. I've done OBGYN and peds.
Are you any favorites?
Not really.
Well, what are you leaning towards?
I'm not really sure yet.
And here we have a medical student who is unsure about what they plan to specialize in. Yes, yes, and yes. While some are dialed in from day one, others have no idea. You spend 2 years learning a crap ton of foundational knowledge and the next year and a half sampling, and that's only a few. Students spend between 2 weeks to a month in each specialty. Can you say information overload?
Diastolic collapse of the right atrium and right ventricle.
Tamponade from uremic effusion.
That's why his BP is low?
Yep.
Too much fluid and pressure around the heart, chambers can't fill.
Yep. Cardiac tamponade. Fluid accumulation in the pericardial sac or the tissue that surrounds the heart, which compresses the heart, leading to a decrease in cardiac output and shock. Or in other words, the heart's ability to pump blood. Within seconds, Dr. Robbie, Dr. Collins, and their team have initiated pericardiocentesis, which entails draining the excess fluid with a giant syringe.
Looking for the hyperechoic tip. Very, very slowly. Do not hit that hard. Good. Next, we'll place the guide wire and then the triple lumen catheter.
Pulse ox is 99. Pressure's up 124/78.
Looks like things are back to normal.
That was cool.
This procedure is this dramatic and necessary IRL. The heart can't pump properly when it's literally being squeezed from the outside by trapped fluid, and a well-placed needle can save a life. From an outside perspective, I'm struck by the simplicity of some of these life-saving procedures. Pretty cool to see. But then again, not everything at the hospital is quite so cut and dry.
Oh, bingo, 1 stone, there it is.
Do I need surgery?
You should be able to manage with a low-fat diet.
Patient presents with upper abdominal pain. Medical student assumes gallstone. Medical student finds a gallstone. Case closed, right?
You want an EKG?
For
Heart attacks can present as upper abdominal pain.
A great nurse is an absolute blessing. I mean, even with more experienced doctors, they are able to point out lapses in judgment or information we fail to consider. This is especially true for medical students, who may overlook presentation patterns more obvious to the well-trained eye.
Yeah. No, yeah, that's a great idea. Thank you.
If our patient is doing okay, a full-on heart attack is unlikely, but not impossible. And an EKG will let us know for sure, showing changes to the electrical rhythm of the myocardial tissue, or the heart tissue. He may also have suffered from angina, which is transient reduced blood flow to the heart, which can feel like a heart attack, but is less severe and therefore less likely to cause lasting damage. The sooner we can identify damage to myocardial tissue, the sooner we can address improper oxygenation to the heart, the body, and its organs. And you know, despite the many variables, I find dealing with physical injuries way more straightforward than mental health.
David, I wanted you to meet Kiara. She's a social worker here who helps in situations like this. We heard about your father's passing, and we know that can put a lot of pressure on somebody your age, and now having to take care of your mom, That's a lot.
A lot of people have thoughts that can disturb them. If you've had any, it's okay to talk about.
What does that have to do with my mom? She gonna be okay?
Yeah, she's gonna be fine. She's probably got a stomach virus, maybe food poisoning. I think she's more worried about you.
This young man brought his mother to the hospital for treatment, only to find himself in the crosshairs of the medical staff, who are concerned about his mental health.
David. Hey, just give me 5 minutes. Leave me alone.
You may have reason to believe someone is under duress or experiencing mental health problems, but you can't treat an adult against their will. Adults typically have the right to refuse medical treatment, including mental health interventions, unless they pose an imminent risk to themselves or to others.
Robbie! Robbie!
So in this case, even if David is struggling and Dr. Robbie wants to help him, there's nothing that can be done. Yeah, this show does a great job at presenting many of the challenges doctors face every day, and it can be a lot, especially.
Robbie, we need to intubate here.
Dr. Adamson just went down with a pulse ox of 65.
Yeah, the pandemic really sucked. And I'm glad the writers chose to shine a light on the harsh realities of that here. As if the hospital and staff aren't dealing with enough problems already, here comes COVID like a difficulty multiplier from freaking hell, bro. Short on beds, short on supplies, short on personnel, death around every corner. Necessary decontamination and quarantine procedures complicating even the most basic of tasks.
Trying to really identify what's happening with practitioners right now post-COVID.
Many of my viewers and subs suggested for some time that I take a moment to review this show, and I'm glad that I finally took the time to do so. Of all the medical dramas that I've watched over the years, this is the one that I feel most accurately captures what goes on. Although perhaps it is just that I am at a point in my career where I can better understand what is happening around me. Either way, there's a lot to love about this show, and as a medical professional, I do feel seen. What we do on a day-to-day basis is challenging, fascinating, and heartbreaking, and doesn't need a lot of dressing up to make a great TV show. I can definitely see why people are excited about The Pitt. That being said, it is not without its flaws, which I plan to cover in another video on this channel very soon. Keep your eyes peeled, interns. Thanks for joining me in this discussion about The Pitt. If you have a comment, leave it below. Here on the channel, we're working towards a goal of 1 million subs, and we would appreciate if you could help us get there. Don't forget to follow my gym, Huba 2.0 Fitness, for free right here on YouTube, where we post content that helps you move better and prevent injury. Or its sister channel, Human at Home, where we show you how to be healthy in the space where you live. Otherwise, as always, that's been a word from Dr. Chris Raynor, not your everyday ortho, where we see one, do one, teach one.